And then when I switched to a eating disorder career, I confronted the same suicide attempts, but all of a sudden there were completed suicides. Never had I experienced so many deaths. And then as I kind of read the literature, it just was quite clear, and the research supports it, that our patients with eating disorders, they don't die of malnutrition, they die of completed suicides. So that's where my light bulb went off, is what's going on here. And it's sitting across from me. It's a very malnourished brain. And that's where the last 16 years is trying to look at some of the biomarkers that might help us predict suicide completion.
Welcome to the Mind Health 360 show. I'm Kirkland Newman, and if you or your loved ones suffer from mental health issues such as depression, anxiety, insomnia, poor memory, poor attention, mood swings, exhaustion, stress, etc., I interview the leading integrative mental health experts from around the world to help you understand the root causes of these symptoms, many of which may surprise you, and suggest solutions to help you heal over the long term. If you want further information, please go to www.mindhealth360.com or find us on social media. I'm so excited to welcome Dr. James Greenblatt once again on the Mind Health 360 show. So Dr. Greenblatt has already been generous enough with his time on the ADHD interview that we did a few months ago. And he's written a brilliant book called Finally Focused, which is breakthrough natural treatments for ADHD. But Dr. James Greenblatt is a child and adolescent psychiatrist based in the US, and his specialties are, apart from ADHD, eating disorders, suicide prevention, and he also does Alzheimer's prevention. He's just fantastic integrative psychiatrist. And so I'm very grateful to have him on the show once again. Today we're talking about suicide, and it's a two-part series. This is part one, and I'm interviewing Dr. Greenblatt on the biochemical approaches to suicide and sort of the risk factors for suicide, the biochemical root causes, and his experience. He's had a lot of experience working with young people, especially with eating disorders, who have a disproportionately high number of suicide rates. And part two will be an interview with Kevin Hines, who is a suicide survivor who jumped off the Golden Gate Bridge and has become an anti-suicide advocate. So combining these two approaches, I think it's really an important thing to look at, given the high numbers of suicides. At the moment, just to give you some statistics, about 800,000 people die to suicide every single year, which is one person every 40 seconds, and twice the number who die from homicide. These are WHO statistics, the WHO. There are indications that for each adult who died by suicide, there may have been more than 20 others who have attempted suicide. It's one of the leading causes of death amongst young people, and it accounted for 1.4% of all deaths worldwide, making it the 18th leading cause of death in 2016, and in some countries that number goes up to 5%. More than 1 in 20 people make a suicide attempt at some point in their lives, and their choice of method is the most important determinant of whether they live or they die. Rates of females completing suicide under 25 has increased 93.8% between 2012 and 2020. And in the UK, death by suicide rose by 10.9% in 2018. Now, Dr. Greenblatt, you may have some further statistics to add to this, but clearly it's a tremendous problem.
Absolutely. I think the statistics over the past year or two have gotten very confusing, as depending on who you're looking at, and so the numbers are changing slightly, but the bottom line is rates are increasing pretty dramatically across all genders and ages and socioeconomic backgrounds. So it's a huge public health problem.
It's a huge public health problem. And one of the things that my understanding is correct, Dr. Greenblatt, you worked a lot with young people with eating disorders. And what you found, from my understanding, is that over the 16 years that you were working in general psychiatry, you'd never seen the rates of suicide that you then saw when you were working with eating disorders. And I think I'll let you talk about this, obviously, but that's how you came to become interested in this subject and came to adopt a more biochemical approach. Can you talk us through your background here?
Sure. I mean, I think so. In reality, for 35 years, every professional day that I worked, I was on an inpatient psychiatric unit talking to patients that have attempted suicide. 35 years, thousands and thousands of patients across 4 states. So it's just been what I've been doing every single day. And half of that time was on inpatient adolescent units, adult units where someone attempted suicide and they were in the hospital. And I had a traditional kind of way of thinking about it. What's going on in your life? Are you depressed? What was the kind of risk factors? Was there trauma in your life? And then when I switched to a eating disorder career, I confronted the same suicide attempts, but all of a sudden there were completed suicides. Never had I experienced so many deaths. And then as I kind of read the literature, it just was quite clear, and the research supports it, that our patients with eating disorders, they don't die of malnutrition, they die of completed suicides. So that's where I kind of, my light bulb went off, is what's going on here. And it's sitting across from me. It's a very malnourished brain. And that's where the last 16 years is trying to look at some of the biomarkers that might help us predict suicide completion.
It's very interesting because, there's a lot of skepticism still in the medical and the conventional psychiatric world around nutritional psychiatry, and people saying, well, nutrition, it's all a bit woo-woo, etc. And I think for you, being a conventional psychiatrist who then saw the effects of malnutrition firsthand and the translation then into completed suicides, did that make you more interested in integrative psychiatry and in nutritional psychiatry, thinking, okay, well, there's clearly a big link here, because when you look at people who are malnourished, whose brains are malnourished due to their eating disorders, they end up having a much worse mental health profile, generally among the psychiatric patients. Was that sort of what happened?
Well, I think in relation to suicide, yes, but no, I went to medical school interested in integrative and nutritional psychiatry, and that's how I looked at depression and ADHD, but it never clicked with suicide because I, like everyone else, thought it was a kind of intolerable reaction to psychic pain and stress, and never really thought of a nutritional connection until, my work with the eating disorders over the past 17 years.
Understood. And so if we're going to look at what the sort of risk factors are from a biochemical perspective for suicide, what would you say are the top risk factors that one should look for in suicide risk from a biochemical perspective?
It's a very kind of long answer, because I think when we talk about risk factors, we're complex as humans, and suicide is kind of the ultimate expression of the complexity of how we kind of see ourselves and make decisions. So there are some standard risk factors in terms of what, as psychiatrists, we've been trained for 100 years. So a history of trauma, history of loss, being alone, grief, all the kinds of psychosocial factors that we look for. But understanding that for 30 years hasn't affected the rates. Treating depression screening hasn't affected the rates. So these biochemical markers that I've been looking at have been clearly documented in the literature for many, many years. And it's just really both sad and appalling to me that it's not integrated into our assessment or treatment. We can, so the list that you asked for, we might start with inflammation. Nutritional deficiencies might affect it, but we have literature across many disciplines that markers of inflammation predict suicide risk. And there are many ways we can look at what could cause those inflammatory markers. And that's part of my list. It could be a head injury, much higher rates of suicide. It could be a vitamin D deficiency, much higher rates of suicide. It could be any number of other kinds of stresses or trauma. We know that trauma in childhood precipitates a chronic inflammatory process in the body that we can pick up 30, 40 years later. So the kind of most biggest overarching mechanism of suicide and sleep deprivation causes inflammation. Those have all been associated with increased suicide risk. And those are simple biochemical parameters that we can both test for and treat.
And things, for instance, like toxins as well. I mean, toxins such as heavy metals, pesticides, molds, mycotoxins can also create an inflammatory response. Would you agree with that?
Absolutely. COVID-19. I mean, it's hard not to bring up, infections that we're struggling with now.
Infections, Lyme disease, Bartonella, COVID-19, EBV, Epstein-Barr, can all create an inflammatory response. But then how do you explain that some people have higher levels of inflammation with the same exposure than others? Is it sort of like a number of different factors? Like, why are some people, one, more susceptible to inflammation, and two, maybe some people with the same levels of inflammation will have more psychiatric symptoms than others who might have the same level of inflammation?
Yeah, I mean, I think it's part of that complicated, multi-variable kind of process of what makes us do what we do. And that's that genetic kind of environmental dance. Certainly, one variable, and I don't want to simplify it, but would be kind of vitamin D levels and genetic polymorphisms around vitamin D certainly has an influence on both inflammation, serotonin metabolism, and suicide risk. But if we multiply that by 10 other variables, we can begin to see the complexity of why one individual under the same conditions might have no reaction. One person might get depressed, and one person might be so overwhelmed and take their lives.
So it's really difficult because there's you have to look at presumably all the factors, which is one of my big bugbears with Mind Health 360, is you have to look at it from a 360-degree perspective and really look at all the factors that could be impacting a person's biochemistry. You have to look at the biochemical factors, such as gut and hormones and toxin levels. You also have to look at the psychospiritual factors such as trauma and stress. And then, of course, lifestyle factors such as sleep and exercise. And in terms of suicidality, I know that there's some key biochemical factors that can really impact whether somebody is suicidal or not, just from a biochemical perspective. So you mentioned vitamin D. I know that there is an issue around fats as well. Can you talk us through sort of the key biochemical markers that you've seen correlated with suicidality?
Sure. I mean, again, many years of research has demonstrated that low fat, and we can interpret that as low levels of total cholesterol, has been associated with increased risk of depression and violent suicide. And these are extremely low levels of cholesterol, unrelated to dietary intake, 30 plus years of research, and everybody writes about it, but nobody does anything about it. Nobody is testing these kids. And again, 35 years on an inpatient unit, we look at cholesterol levels, and those kids that came in with these violent attempts, the hangings and the gunshots, occasionally might have that very, very low total cholesterol. The other fat that's been associated with suicide is low levels of omega-3 fatty acids. And again, research over many, many years, the US military has not only done research, but they are so convinced there's a relationship that they supplement both some of their foods, and there's research studies looking at adding omega-3s to the diet of active duty soldiers to prevent suicide.
And has that been effective? Have they done any measures of sort of studies looking at the effects of that? Or is it too early?
Yeah, there hasn't been a lot of outcome measures. I mean, we just collect data saying Yeah, low omega-3s are associated with suicide, low total cholesterol. And there's just not a lot of good outcome data or taking this literature serious enough to institute public health measures to address it.
And I mean, one of the problems is in our societies, cholesterol is seen like the bad guy, right? I mean, statins are one of the most commonly prescribed drugs out there to lower cholesterol levels. So how do we deal with this? That on the one hand, cholesterol is seen as this bad guy and that, you have to go on statins to reduce it, versus the fact that low cholesterol is very associated with mental health issues and suicidality. Are they different types of cholesterol? Is it LDL versus HDL? And what are the numbers that we're actually talking about so that people can get a sense of what we really mean by low cholesterol?
I think I've been dealing with side effects of statins as a psychiatrist for many years, and now there's FDA labeling. So there is cognitive changes for statins if cholesterol gets too low. Usually memory, sometimes depression, but it's different. The low cholesterol due to statin use is different than a term that I just made up called very low cholesterol that is likely genetic, where their numbers, the research is under 140. We've seen under total cholesterol of 120, 100. And that is likely genetic because it is unrelated to diet, unrelated to statin use. Some of the kids are eating junk food, eating a lot of fat. So those numbers we've seen clinically and associated in the research as much higher risk for actually violent suicide attempts.
That's fascinating. And in terms of diet, veganism, for instance, I know that there's a higher correlation of eating disorders with young women, for instance, who are vegan or vegetarian. And my understanding was always that, okay, well, if you're a vegan or vegetarian, you're likely to get less cholesterol or have lower levels of cholesterol and lower levels of fats. And of course, lower levels of vitamin Bs, B6, B9, B12, which are also key for mental health, as well as lower levels of protein and the amino acids required to make the neurotransmitters that you need, such as serotonin and GABA, to calm down and to be happier. What would you say in terms of diet? I mean, have you noticed a correlation between certain diets and risk factor for suicide?
Not really. I do think that most of what we're describing in the literature is likely genetic vulnerabilities.
Okay.
And genetics are really important. You can do a family history. I mean, Hemingway's family, there's 7 or 8 suicides. So suicide has some genetic vulnerability. Now, certainly for some individual, a junk food diet with lots of processed food might kind of fuel the flames of inflammation. So if we put that on top of vitamin D deficiency and other factors, yes, maybe. And vegan vegetarian diet, cholesterol is usually not a problem because our body makes most of the cholesterol. So we don't really see dramatically low cholesterol levels. We do see low omega-3s and low B12 and zinc. And again, with the right genetics, it could be a problem. For someone else, they could live, happily to 150 with a vegetarian diet. So it really kind of depends on that genetic environmental dance, if you will.
And are there any genes? I interviewed a lady the other day who runs a genetic testing company, and we were talking about the genes associated with different mental health issues. What would you choose to test? What are the genes that you would look for, the genetic variants that you would look for to for mental health issues and suicidality?
I don't know if there's anything directly correlated with suicidality that clinically that's been important to me, but I do think looking at MTHFR, metabolism of folate, is certainly for many years been something we've been looking at for treatment refractory depression, and that certainly is a risk for suicide. So individuals that can't metabolize folate efficiently, particularly some of the homozygous variants, the TT variant, has been associated with treatment refractory depression, and adding a higher dose folate can dramatically improve the depression.
And why is folate so important for mental health, essentially?
Well, folate is kind of one of the cofactors in the synthesis of all the major neurotransmitters. So to get adequate dopamine, norepinephrine, serotonin, you need adequate L-methylfolate, which goes on to make SAMe, and that's how the last step in the synthesis of all these major neurotransmitters. So as folate is poorly metabolized and it's not available, we know there are lower rates of depression. That's been studied for many years, and clearly depression's a risk factor for suicide.
Understood. And what about the other key B vitamins? Because I know that, for instance, B6 is also an important cofactor for serotonin and certain other neurotransmitters. B12, can we test for those genetically? And would you test for those and looking at people's nutritional status?
Absolutely. I mean, in my world as an integrative functional psychiatrist, I would look at B12 and B6 and all the B vitamins for every patient that walks in the office with depression. There is not the dramatic literature on those nutrients and suicide risk as we have with the fats and vitamin D and inflammation. And we should talk about lithium as well as a deficiency associated with suicide.
Yeah, lithium is key. And I know that you're very experienced with lithium, nutritional lithium, rather than pharmaceutical lithium. Can you tell us a little bit about lithium, how you test for it, why it's so important, and how you would remedy a sort of lithium deficiency?
Sure. First of all, lithium is a trace mineral that's in our soil. It's also a drug. So people have when you mention the word lithium, people get scared and they think about a pharmaceutical. But it is on the periodic table. It is an element that's been around since the Big Bang, one of the first elements in the universe, and it's in the Earth's crust. So we need a little lithium for health. The most dramatic research that's been going on for many years, and new studies came out this year in 2020, showed that the amount of lithium in your water supply, micrograms naturally in your water supply, predicted suicide risk. So this is micrograms of a trace mineral lithium in the water supply. Some of the new studies came out of England, very carefully looking at all the research over the last 30 years. And it's really dramatic. It is so dramatic that people are wondering, well, should we be adding lithium to the water? So we know that these tiny microgram dosages can prevent suicide. And many studies have demonstrated that.
And so would you prescribe, for instance, if you have a patient who comes to you who has suicidal ideation, you would obviously do all these workups and look at all these deficiencies. What sort of dosages of lithium would you give? Would it depend? I mean, I know you do very personalized medicine. Would it depend on the patient's profile, or is there a level that we can all safely take to help protect our brain? Because I also know that lithium is a neuroregenerative mineral, and it encourages BDNF, brain-derived neurotrophic factor, for instance, and that it encourages neuroplasticity. And so in some ways, I sometimes think we should all be supplementing with lithium.
Well, most days I think that too. I do think one of the areas that traditional psychiatrists around the globe would agree is that prescription lithium has anti-suicide properties. So we do now have clear research looking at the pharmaceutical having anti-suicide properties. And we have clear research looking at micrograms in the water supply having anti-suicide properties. So for my 35 years of practice, I've been using dosages somewhere in between that are safe and simple. And that is the 1 milligram to 5 milligram dosages where I've seen clinical improvement in irritability, impulse control, mood, and just extrapolating from the rest of the literature that there's likely anti-suicide properties. So 1 to 2 milligrams is kind of the is probably the dose most of us would need. I believe that there are also genetics that some of us need higher dosages.
Understood. And also in terms of neuroregeneration, I know that you've got a book on Alzheimer's, and one of the things you mention in that book is sort of lithium, the importance of lithium. if somebody is having sort of dementia symptoms, would you increase that nutritional lithium dose? I mean, presumably you just customize it to the patient. But again, if say my mother has dementia, would you say, okay, she should be taking 2 milligrams of lithium a day?
Well, I think that one of the things that we've finally not only understood, but now is in the literature, that the progression of dementia and Alzheimer's is a 30 to 40-year process. So lithium is at its best as a preventative agent in all the biochemistry surrounding kind of neuroinflammation and brain degeneration. So lithium is most effective as a preventative agent over those 20 or 30 years. Okay. There is some research where people have looked at adding lithium to early cognitive decline, early signs of dementia with improvement. I think someone with Alzheimer's, it's a bigger stretch, and there's no research to really support that. So, I'm recommending these, 1 to 5 milligrams as a preventative strategy. Clearly, as someone becomes more ill, there's people doing research on Parkinson's disease and on Alzheimer's, looking at higher dosages.
Understood.
We're actually in April, we'll be having a full conference, 2-day conference on lithium with all the researchers around the globe doing some of this research on Parkinson's and suicide prevention and how to understand the relationship to Alzheimer's and dementia.
That's interesting. So I'll have to get the link to that to put in the show notes. And then in terms of other key nutrients for anti-suicidality, I mean, you mentioned zinc, for instance. Are there other sort of key nutrients that come to mind that you would recommend looking for deficiencies in and then supplementing with?
Well, I think in overall health, if you feel better and your mood is better, you're less likely. But those that have the most dramatic relationship to suicide might not be nutrients, but might be kind of behaviors, if you will, that cause inflammation. So sleep deprivation, I think it's important that we kind of discuss that for a minute. So sleep deprivation in the latest edition of the American Psychiatric Association's book on suicide prevention, this edition, finally, there's a full chapter on suicide, on sleep as a risk factor for suicide. So sleep deprivation, many good studies. And the nutrients are what we discussed, mainly the fats, the vitamin D, and the lithium. And the other, I think, important thing to discuss and might be controversial would be medications. So we know that the antidepressant medications that people, clinicians around the globe are prescribing for suicide have a risk factor of increasing suicidal ideation.
So what do we do about that? And I've heard sort of different views on that. I mean, some people say, well, if you're already suicidal and you take these medications, they'll increase your serotonin, which will then increase your courage and increase your drive and increase the drive that you might have to actually kill yourself. Is that how you would explain the mechanism of how these drugs might enhance suicidality?
I probably wouldn't explain it that way. That was kind of an older way that we would think about it many years ago. At this point, again, when shifting to eating disorder work 17 years ago is when I saw this very frequently. So, first part of the career using these antidepressants, I never saw acute suicidal ideation on these antidepressants. But then with eating disorder patients, I spoke to many young women and men. They were put on these antidepressants. They got these intense, intrusive thoughts of wanting to kill themselves. And so again, I started making the connection between malnutrition affecting this suicidality. So I've seen it, it's real. You stop the antidepressants and the suicidal thoughts go away. So my interpretation clinically in the literature is that for some individuals, mostly during the first 30 days of medication use, if they develop any thoughts of suicide, you stop the medication. If somebody's been on the medication for 6 months, it's less likely to be a medication side effect.
And what causes this, do you think, the actual medication side effect of suicidality then? Like, why would a medication that's designed to make you feel better mentally actually enhance the risk of suicide?
I don't think we know or have that answer that these medications, most of the ones, or the ones that I've seen, even though there are warnings on other ones, increase serotonin. So I think it's this increased serotonin in a vulnerable individual has to be one of the mechanisms. We don't understand the cause because somebody else might take the same medicine, their mood improve, and suicidal ideation goes away.
Yeah, understood. And in terms of your eating disorder and the higher correlation between young people with eating disorders and suicide, how would you treat the eating disorders, essentially, presumably in the same way? I mean, you'd look at all the nutritional factors and the fats, etc. And is that the main approach that you would use?
I think there are a couple approaches. I mean, there's this biochemical biomarkers that I'm discussing. And so to understand those markers and treat them. And then there's those other risk factors we talked about: trauma, loss, connections to other people. And then, we can't forget particularly for our adolescents, the whole social media, we call it the gasoline on the fire that can create the toxic environment for these kids whose brains aren't developed completely to follow through with suicide when they feel just desperate and hopeless.
I was going to ask you about that, the whole social media thing, because there has been, I know, since the advent of Instagram and Snapchat in 2011 and 12, there's been an exponential increase in mental health issues in young people. And, you can track that on a graph, and it's very obvious that it correlates with the advent of social media. And, and then there are these programs like 13 Reasons on Netflix, which was all about suicide. What's your view of the sort of culture that we're in for young people? And how can we address the sort of prevalence of this culture of unhealthy social media use and the culture maybe of normalizing suicide? What's your view on that? Because it seems to me that it's a big problem and it's a new problem that we're not quite sure how to come to terms with yet.
Yeah, it's frightening and actually enraging. So I saw the first episode of 13 Reasons when it came out, and then I wrote an article saying that this was both horrific and in poor taste, and it just glorified suicide. And subsequent research has demonstrated a number of different ways that there was an increased suicide rate following that show for those individuals, the demographics who were watching that show. Wow. And I think they did a couple more seasons and they took out the blood, but it was the same theme and it was really tragic. So we know that particular show caused an increase in suicide. And we know that, as you described, the social media, both comparisons and encouragement of hurting yourself and getting that kind of both negative and positive feedback has intense repercussions for the developing brain of a young adolescent or pre-teen. So it really is, it's tragic. And I don't think we're doing enough to both monitor it or address it.
And I wonder, what can we do? I mean, I have 2 teenage boys and their attachment to social media is ubiquitous and sort of constant and daily, as are their peers. So, what can we do as parents to try and address this in a culture which, it's like a tsunami? I mean, how do we as individual parents try and deal with this and protect our kids? And can we and should we?
Well, I mean, as a parent, I certainly understand, and as a professional, I do not recommend that we take away, phones for life and social media. It's just part of our culture. So I would work backwards, and I describe this suicide kind of risk factor as a forest fire, the kindling of a fire. So, and there are many factors that contribute to that. So some we talked about: nutritional deficiencies, self-esteem, treating the depression. We didn't mention substance abuse, the nutritional deficiencies. So if we can, those are all kind of kindling for this fire. And then to me, the social media is the gasoline on the fire. And we probably aren't going to be able to police that as parents the way we would like to. But we can address all the other kinds of issues for our kids, making sure that we're monitoring for nutritional deficiencies, and we're getting them in therapy if there's bullying and stress and traumas. And then we're understanding if they're, utilizing drugs or alcohol. Those things I think we can, as parents, address and aggressively treat. I think the social media, the phones are a train that we cannot stop.
I would probably agree with you. Unfortunately, I think you're right. And that brings me also to the inflammation. I mean, you talk a lot about inflammation as sort of key factors in depression and mental health issues and suicidality. And you mentioned sleep and nutrients and stress management. Are there any other factors that you would say sort of easy, low-hanging fruit to treat inflammation and to minimize inflammation in the brain, apart from the ones we've mentioned?
I mean, I think any kind of stress, and that could be different for everyone, and that could be from a junk food diet to, more significant trauma, can affect inflammation. So I think the model really has to be identifying all the sources of stress and inflammation and treating them, and not just kind of picking one and focusing on that. So, we have nutrients in the omega-3s and magnesium and curcumin that might decrease inflammation. But for an adolescent or adult who's struggling with major mental illness or depressed or thoughts of suicide, I mean, that's not sufficient. So that's why I'm very cautious of talking about things like other anti-inflammatory agents, because someone who's severely depressed and at risk for suicide, we need to dig deeper. We need to look at all the biomarkers. We need to look at all the psychosocial factors and provide the safety net to treat. And it's just preventable. And I think that's the tragedy.
I agree. And the other thing we haven't really mentioned is gut as well. I mean, when you say dig deeper, I mean, looking at gut markers, the microbiome, which can also be a huge source of inflammation, and any sort of pathogenic bacteria, for instance, in the gut, like C. difficile or, HPPA, which I know you mentioned for ADHD. These presumably are also very important factors to take into account.
Yeah, absolutely. I mean, I think we can think of the gut as a major source of inflammation, certainly from early childhood, whether it's an inflammatory bowel illness or overgrowth of bacteria, but that can drive the whole process of inflammation. And we know there's a direct connection between the gut and the brain now.
Yeah, understood. And then finally, before we wrap up, just a couple more questions. So I'm interviewing Kevin Hines later, who is a suicide survivor, and he has a very severe case of bipolar disorder with psychosis. And someone like that, he had massive childhood trauma. He had very poor nutritional status as a baby. I mean, he was fed sort of Coca-Cola and sour milk and some very sugary foods as a baby. And obviously he has this bipolar with psychosis. So there's clearly a sort of perfect storm of nutritional deficiencies, trauma, genetic factors, etc. But, even now, 20 years after his suicide attempt, he still struggles with suicidal ideation, on a very regular basis. And so for him, it's a real battle, a daily battle where he has to implement his sort of lifestyle routine and do his exercise and his visualizations and his nutrition, etc. And it's a real discipline for him to essentially stay alive. Somebody like that who has that sort of brain disease, the bipolar disorder with psychosis, how would you approach that? And do you think, he is on meds, but do you think it's something that can be at some point healed, or is it just going to be a daily struggle for the rest of his life?
I guess I wouldn't keep doing this as a career if I didn't feel that there was hope and it could be healed. And I'm pretty optimistic with the right integrative treatment, and that might be nutrients with medications. Obviously, there are many individuals that the genetics are so powerful that we can't. But absolutely, I do think with the right combination of nutraceuticals and pharmaceuticals, that in my experience, we should be able to damper those suicidal thoughts and improve the mood. And lithium is certainly a key nutrient in that matrix.
Understood. And then one final question, the work of, at the moment, the most recommended form of therapy, especially in the UK, I don't know about the US, is CBT, so cognitive behavioral therapy. And I know that that's used a lot in eating disorders and any other sort of mental health issues. But there's a whole section of trauma therapy, which is somatic based. So Peter Levine, Bessel van der Kolk, Stephen Porges have a much more somatic approach to therapy and a more nervous system based approach, which has been proven to be highly effective for trauma. But this is it's a niche approach. And at the moment, the government guidelines are all about CBT, CBT, CBT. And yet the outcomes for trauma are much better when you look at these somatic therapies, whether they're somatic experiencing, EMDRs. There are different types of somatic therapies specifically for trauma, which are not mainstream, but they've been proven to be highly effective. Do you have experience with these, and do you feel that we should be moving more in that direction?
Yeah, absolutely. I mean, I think trauma is, more rampant than we want to acknowledge and we can accept as a culture, across the globe. And it is a precursor to major mental illness and certainly suicide risk. Incredible high rates of trauma in those that attempt and complete suicide. And CBT is not an effective model for trauma, and many of these somatic therapies are helpful. So absolutely, they should be incorporated into a treatment plan.
And what's the situation in America? Because I know in England, the NICE guidelines, in the NICE guidelines for mental health issues, there are two recommendations. One is antidepressants, mainly SSRIs, and the other is CBT. And those are chosen because they're the most evidence-based. And there is no mention of any other sort of therapies or, and this to me is a real problem. And because that's just the tip of the iceberg. And as you say, CBT is not necessarily effective for trauma. Is it the same in the US, or do you find that there's more openness towards alternative therapies as given in sort of national guidelines?
Well, I think in terms of suicidal ideation and attempts and self-injury, so DBT, dialectic behavioral therapy is a recommended standard in the US. And so that is a little more both evidence-based and helpful for the complexity of many of these chronically suicidal patients. So it's not a standard CBT, it's a DBT model. So that has been helpful. The somatic therapies are probably more available here, but they're not necessarily covered by health insurance and not necessarily built into mainstream therapies.
Understood. And I think one of the issues, as with all these treatments, is that we need to really gather a body of evidence to convince essentially governments and mainstream psychiatrists that this is really the way to go. And I know there is evidence, but maybe there's not enough evidence. And I think that's something that needs to be worked towards, because certainly patient outcomes are extremely improved with these somatic therapies, but maybe there's not enough evidence to demonstrate that. I'm not sure, but it seems to me that there's a real gap here in terms of the delivery of treatments that are effective, and that needs to be addressed if we're going to treat suicidality and other serious mental health disorders and trauma more successfully.
Yeah, I mean, I think psychiatry and the field of mental illness, we've struggled for hundreds of years to find a model, and we somehow rested on a psychopharm medication model. So that kind of just envelops so much of the treatment, and it's just an oversimplified model, and we miss many of the aspects of treatment that you're describing.
Understood. Well, Dr. Greenblatt, that was incredibly helpful, and I'm very grateful for your time. Is there anything else that you need to add? I mean, I think we've covered most things, but anything that you would like to add before we close?
No, I think we hit upon most aspects. I don't want to oversimplify it, but I do believe there's a biological difference between those individuals that think of suicide and those individuals that make a violent, aggressive attempt. And if we can look at those biomarkers, we might kind of take a step towards prevention. I think the most important thing that I've seen in 35 years, as well as the research, is no treatment other than staying connected with an individual after leaving a hospital, after leaving treatment, or is when those are most vulnerable. So any program that links individuals at risk to another individual is probably going to be the most effective treatment we have for preventing suicide.
Yeah, I agree with that. And I've heard Kevin talk about the fact that, just reaching out to people and talking to them and actually getting them to talk to you and say whether they're contemplating suicide is already a huge step in preventing an actual completed suicide. So I agree with that. Connection is incredibly important. Well, Dr. Greenblatt, thank you so much for your time. And thank you for all the work that you do in terms of helping mental health really around the globe and with our children and adolescents. And keep up the great work.
Thank you for having me. Take care.
Thank you so much for listening to the Mind Health 360 show. I hope that we've helped you realize that your mental health symptoms have root causes that can and need to be addressed in order to sustainably heal, and have given you some ideas about steps you may take to start your healing journey. Please share this interview with anyone you think may find it helpful, and if you want further information, please go to www.mindhealth360.com or check us out on social media. This information is for educational purposes only and is not intended to diagnose or treat any disease or to replace medical advice. Please always consult your healthcare practitioner before discontinuing any medication or implementing any changes in your diet, lifestyle, or supplement program. Thank you.